Evening, everybody. It's 5:30 p.m. Welcome to today's discussion, Transforming Health Access in Kenya. I hope you had a great day, and it's my pleasure just to welcome all of us to this discussion that kind of, has a specific focus for Kenya, and particularly Narok County. I know some of us, we could be thinking about, why are we here? So even as we begin our discussion on transforming health access in Kenya, it's very fundamental to first reflect on what we mean by access. Health access goes far beyond the presence of hospitals or clinics. It speaks to whether people can physically reach, afford, and confidently use the healthcare services they need, when they need them. It is shaped not only by infrastructure, but also by geography, mobility, safety, culture, and the broader social and economic systems in which people live. Across Kenya, we continue to see deep inequalities in access, especially for rural and hard-to-reach communities. For many, the nearest health facility is still several hours away by foot or boda. That's a motorbike. Mm-hmm. These physical distances often translate into social and health disparities. Talk about delayed treatment, missed vaccinations, and preventable deaths. Access, therefore, has two dimensions. The potential, in other words, how close and available services are, and the realized, whether people can actually use them without barriers of distance, cost, or social exclusion. In Narok County, this presents a unique picture. This is a location where pastoralists and mobile populations commute from one facility to another in search of better health care. We sometimes see these communities and organizations as trying just to get the best out of what exists. Yet sometimes also we see hope in how communities and local organizations are reimagining their care. For example, through mobile outreach clinics, digital health innovations, or culturally grounded approaches that bring services closer to families. Today's conversation invites us to think beyond infrastructure to understand health access as a matter of equity, dignity, and inclusion, where true transformation happens when geography, income, or identity no longer determine who gets care and who is left behind. In this spirit, organizations like Community Health Partners are leading the way through mobile outreach clinics, integration of traditional and modern health systems, digital tools for tracking health services across the community. These community-driven models demonstrate that when care is brought closer to people and interventions are co-created with local voices, health systems become more equitable, resilient, and sustainable. I'm truly honored today, even as we think about health access, to be joined by John Sankok. John Sankok is the Director of Community Health Partners, whose leadership has been pivotal in designing and implementing community-driven health solutions in Narok. So just to begin our conversation, John, could you start by sharing what inspired you to work in this space within your community?
Actually, good evening.
Good evening.
Yeah, my name is John Sankok, as mentioned by Professor Julius. Actually, I come from Kenya, southwest of Nairobi, a place known as Narok County, near the Tanzanian border, and have been in this service for more than 30 years, providing healthcare to the Maasai community in the remotest areas between Nairobi and the Tanzanian border. So, and actually what we do, we have started what we call first aid clinics, spread all over the southern part of the Maasai country, and coupled with mobile clinics done either by motorcycles or in some cases some four-wheel drive vehicles to reach the unreached people in healthcare. in order to bridge a gap on people who cannot be able to come to the health facilities.
Thank you, John. Like with these 30 years of experience, looking back, what are the most significant challenges or barriers that prevent the Maasai people from accessing healthcare in these particular settings?
Actually, there are so many of them, but the few of them I can be able to mention is actually, we have what we call the population is sparsely distributed, far from health facilities. In the nomadic way of life, people move. So, if you meet me tomorrow, living in William and Mary, maybe 1 week to come, you'll not meet me there. So another is a poor health network, and in some situation, even cultural barriers, because the Maasai have a deep-rooted culture that make it difficult for them to seek health services.
I like the point of culture. Could you share more about culture and maybe practices that could affect health-seeking behavior for this, particular community?
Yeah, as you know, normally we call them a forest is a moving pharmacy. So before our community come to the health facilities, they try what we call the herbal medicine, and they come to the facilities when the conditions are already bad to be able to make an intervention. So it's actually one of the big challenge whereby they report the facilities late to be managed. So
have you, how does it play out? If you have a real life example of when somebody reported late, what did you do as community health partners? What action did you take in such instances, if it so happens to be the case?
Yeah, it is a very challenging situation. When somebody travels all the way, maybe 100 kilometers to a health facility, and then when you try to make an assessment, you cannot be able to help that person. Because even the referral systems are still very difficult, and maybe the vehicles that will take that person to a hospital, which is about 100 kilometers away, the vehicles are not available. So probably what you do, you try to do what you can't and manage that person, regardless. Because normally some facilities are staffed by maybe nurses or even clinical officers or physician assistants. So you just do what you can't to manage that person.
And again, I know for this location, Narok, you talk about distance to the health facility, availability of human resource for health as issues that affect the uptake of health services. What about safety? We know that Narok is within a national game reserve. Is safety an issue for this community when it comes to health services uptake?
Yeah, of course, safety is a big issue because, if there are no vehicles, there are no border or the motorcycle in that case. People are forced to move or to walk. So imagine walking through thickets or forests or bushes with elephants, lions, and all dangerous animals, carrying a sick baby or maybe a mother in labor. It is very, 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 very challenging. So that's a very big challenge.
Thank you. Again, looking at the human resource for health for this particular community, we understand that, Kenya being a low-income context, we have some funding issues. So how does it affect you in terms of your service delivery? So in terms of availability of nurses, clinical officer, like you mentioned, and then maybe also to tie to that, you could talk to maybe supply gaps when it comes to procuring the much needed vaccines or maybe health equipment or services that will need people to spend money. How does it play out in your context?
Yeah, actually, human resource for health, nurses and physician assistants or any health workers, it is very difficult. You see, I don't know whether it is a practice here in the US, but in Kenya, most of the health workers prefer to work in cities or work in towns where life is a bit more easy. But in our case, it takes a lot of effort to be able to retain health staff in the rural health communities. That means sometimes retention is very poor. And even the supply chain is very difficult because I've already mentioned that the roads are pathetic. Many vehicles cannot be able to make it to the rural areas to supply medicine. And we get our supplies from Nairobi, which is 150 kilometers away. And so it is, when you have stockouts, it is very, very difficult to refill. So you have to be very technical in ways of trying to make sure that you order things in good time.
Thank you so much. It's again, thinking about this area in terms of health, human resource for health. I'm just imagining if you were to select a given cadre that would maybe optimize health outcomes for the Maasai population. I know every cadre is important, but who would you prefer in this context? Because I know you can't afford all the doctors. Probably, if you had a choice to make, which would you choose among the cadres, the nurses, the caregivers, and the doctors?
Yeah, actually, our nurses, they are trained in such a way that it is different from the training to do here. They train what we call the community health, registered nurses who are prepared to do most of the things. They do their midwives, their public health. They can be able to clerk patients, do diagnosis, and at least do some primary health care, work. So we really prepare nurses. We prefer, because we can be able to keep them and afford them. And sometimes they're also willing to stay than the other medical cadres like doctors and physician assistants.
Yeah, and then again, in terms of, like John mentions that he prefers nurses. So just to give us context, in Kenya you'll find that a nurse would be doing many kind of tasks. There's always a specific task that a nurse should do. Maybe care for the sick. But again, in this context, you realize that a nurse is in charge of the, computing system, where if a child is to come to the clinic, they have to enter their details. And that is why this is a very probably important cadre when it comes to healthcare provision, particularly in contexts such as this. I just want us to move forward and also think about, solutions and also innovations. Because we can, define all this, but unless we have innovative solutions, then of course we might not be making the steps. With your 30 years of experience, could you probably share some of the strategies community health partners has put in place to improve healthcare access? You mentioned mobile clinics, but could there be other strategies that have been effective as well?
Yeah, actually, we have what we call community health promoters. It's a network of community health volunteers in the villages that we train so that they can be able to identify people who have health problems in the villages, and they can always bring information to us, either by calling or by walking to the facilities. And we also do, we have some apps that we use to contact the community health volunteers, and vice versa. They still talk to us. They call us and tell us that maybe in a particular village, there is a very sick patient that require our attention. So with the motorcycles, for those who have been there, border, we can always jump on top of the motorcycle and go to where the patients are. Yeah. We actually reach the unreached. People who are not able to come to the facility.
Absolutely. And just to kind of shed more light on the mobile apps, could you tell us more about how they operate and, in order to bridge that gap?
Yeah, actually, you see, every community health promoter or volunteer in that case do have at least a mobile phone. But that is actually new. For many years, these phones were not available, the network were not available. So currently, there's an app that you can be able even to write messages to what we call the health extension workers in the facility, and then immediately will respond. But it will take some time, maybe some time for us to reach to the patient, especially maybe mother in labor, or maybe respond to animal attacks. This is what we call emergencies in the villages.
Yeah, thank you so much. And again, we know that the role of community health promoters is very important, but also thinking beyond direct healthcare services. I know CHP works in other areas such as water, sanitation and child protection. Maybe you could shed light on how some of these, non-health interventions, contribute towards the overall health, within the community.
Yeah, actually what we do, we work within what we call the Mara landscape, where we take care of the environment and conservation. So whatever we do, we integrate healthcare services into environment and conservation. Because you cannot be able to take care of the animals or the environment and you leave the people out. Because health is a cross-cutting issue. So normally they go hand in hand. And we provide a lot of water services. Because in our place, I've seen there's a lot of water here. But where we come from, people do not really care the quality of water. What they need is water. They just need water, whether it's safe to drink or not safe to drink, but what they need is water. So what we do is actually we go a step forward to make sure that people get access to clean water.
Thank you very much. And what about instances where you have programs directing, maybe having programs that are going to maybe protect children? I know as a community, we have instances of, say, early marriages, for example, or maybe there could be some other cultural tendencies that probably might prohibit, health-seeking behavior. How do you normally conduct such kind of programs?
Yeah, actually, in most of our programs or projects, we actually integrate things like gender issues, including early marriages, female genital mutilation. We integrate them into our services. And actually, men in our society are very powerful people. They are the decision makers. So we involve them through strategies like what we call the men forums, where we sit with men and discuss issues. Because they are the decision makers. Women in Kenya or in our community, most of the time, they don't have that power to make decisions. So we involve men in decision making.
So when you talk about decision making, does it also mean that decisions concerning the women as well?
Of course, yes. Man is the final decision maker. Even men can decide whether you go to the ANC clinic or even taking a child to a clinic. They're the ones who are custodian of properties at the home level. So you cannot sell a goat. A woman or a mother when the child is sick, you cannot sell a goat or use family resources without the permission of the husband.
Interesting.
Yeah.
I was just thinking about, the role of men and also the role of women. Do you kind of see some overlapping tendencies from both genders in terms of doing things that probably promote these practices? Like you talk about maybe uptake of NC services, vaccination programs. Because I feel like it's more one-sided, where the man has to make that decision. Maybe you want to do a follow-up visit, or maybe you want to receive a second dose of a given vaccine. So how does it play out if you compare when you started and where we are currently?
Actually, when we started, it was quite tough. But over the years, we are able to do a lot of, advocacy health education, especially targeting the men who are the decision makers and making them understand why they should let some things go. Well, it is very tough. People cannot be able to imagine. If you have not been to that society, women are really, really oppressed. I can say oppressed. And they have no option but to agree on the cultural beliefs of that particular society. But we are somewhere now. At least some men are able to give their women freedom to do certain things when they are not there.
Yeah, so it seems like oppression is getting lighter, or what should we consider that to be, knowing that now women have some autonomy when it comes to making healthcare decisions. And maybe Grace would shed more light on this, but we see a tendency where with more informed community, with more health promotive events, health promotion events, we are seeing a community that can be more secure and seek services on the basis of clinical guidelines and not on the prerogatives of their significant other, and that is something important. Again, when you talk about some of these innovations, some of these solutions, the community is the heart of it. So you mentioned doing some community engagement, you have men forums, but if you could go even more and tell us more about how you organize these forums and how effective they are over time in trying to address some of these challenges that exist within your community.
Yeah, actually, this is a community whereby you cannot force things. Because if you try to force things, they will not give you audience. They cannot sit like the way you are sitting and listen to you. So what we do is actually trying to persuade them to tell us the reason why they do particular practices. And it's always good to drop them to their level and try to engage them. Because if you try to stay up thinking that you know more, they will not listen to you. So you have to be very, very careful not to annoy them such that they will not listen to you. So, but it is practical that now, because of the intervention that we are making, now things are really, really changing. And with Men Forum, it's a strategy whereby if you did today, we were talking to some students here and we had lunch. In our community, you cannot invite people to gather together and then you don't give people something to eat after the meeting. If you don't, they will never come back again. So in the Men Forum, sometimes we slaughter goats, and then after the meeting with men, now they can be able to go and choose something, eat some meat. And that's actually a good way to do that. Yeah.
We just hope that there's something to eat after this meeting.
Yeah.
Yeah. So, it's more like you're pointing to trust issues where, if the community does not believe in what you're saying, they won't trust you. You do want to shed more light on trust, like how is it built? How is it sustained? And how does it work for the Maasai community?
Yeah, actually, the Maasai community, normally we call them, the story of Thomas in the Bible, when, somebody wanted to see exactly where Thomas was speared. Maasai, they can really doubt you until they prove that you are a good person. So you need to be trusted for them to believe in you. And that's why people like some of us who have been in the community for a long time, we are able to do things a bit more easy because we understand them well. We understand what they want and what they don't want. And the approaches are so significant. The way you approach them, will either determine whether they will cooperate or they will not. Culture is deep-rooted in this community.
Thank you. Just to shift and to another gear probably and talk about data and monitoring. Of course, we note that for us to have innovative solutions, data is a fuel. So as a community health organization, or as a community health practitioner, how do you use data? This is maybe in terms of digital tools, we have community registries, field reports. So how do you use all these, resources to drive decision making, to track progress, and even to make programs to be more adaptive to your community members?
Yeah, actually, data to us is very important. Many years back, we did not really, use a lot of data, but these days we really do make a lot of data because our health service has really grown. We see over 100,000 patients a year. That's a workload in our health facilities, and where data is very important for decision making, for budgeting, and I know some of the William and Mary students who are there to help us analyze our data over the years, and the data we have has really helped us to even to do the tracking, to see where we are not doing well. So, and I really want to appreciate the students who have been there for years, since the time of Dr. Camilla, and I know Carrie came when she was very young. And yeah, I know we are doing quite a lot in trying to track data on immunization, defaulter tracing, and also TB. These are things that the data is really helping us make decisions.
And that is very important. So if you look at the greater outlook for Kenya, using these, examples, how do you think this could be replicated for the entire country in terms of the data uptake and just having like community-based registries, community-based data systems? Because what we normally see is that most of this data is generated at the national level. So what is the outlook for Kenya? Do you think we might have a scenario where more institutions or more services are going to be tailored towards community health registries?
Yeah, actually everybody is trying to make sure that we have a clean data, because if you don't have the right data, it will be very difficult to make to get the right data to make decisions, to drive, to make budgets and for planning purposes. So, and what we are doing as we plan for the country data system, we are actually trying to generate our own data bases in our own facilities, or partnering with other people to make sure that at least we have a data system. Yes.
Yeah. So with what currently exists, what could be the gaps within the data infrastructure, or maybe the data systems that we currently have? Have you noted some kind of gaps or deficiencies that probably need to be addressed?
Yeah, actually there are quite a number of them. Because as you know, for people who have been there, one of the biggest challenges is actually the power backups. You can have, the Wi-Fi's, but there's no power to back that. So those are some of the biggest systems. And also the technical staff. Data, you need to have some technical staff to be able to put that data together. And also of course the computer systems, the networking and all that. It's actually still a lot of challenges around. Yeah.
Thank you very much. And just also shifting to another gear where we want to look at policy, and system level, decision making. I know in 2010 we had a new constitution in Kenya, and with the new constitution, the Kenyan health system was devolved to the county level. So, if you look at it, it's now almost 15 years. What changes do you think are most needed at both this county level, the national level, and also the community level to improve health access for rural communities and nomadic populations or hard-to-reach communities?
Actually, for the last 15 years, It's still a challenge because the system at the county level are not really working the way we expect. And although we are struggling to, we are struggling to make sure that things do work, but the technical aspect is still lacking. And also the resources to be able to do all these, system together, the resources are inadequate. So it's still a big challenge. Yeah.
So,
And the healthcare in Kenya is actually devolved. So the national government plays very little in developing the county health systems.
yeah, and actually I was asking that question because I know your position within the Narok County government, the governance structure where is the chairman of the health services department. And I'm just thinking, how could the county, change or adapt to some of these innovative approaches like we have in CHP, where we have a very robust, health registry. Is there anything that the county could learn from that?
Yeah, actually, for those who have been to Ewasungiro, normally whenever maybe the big bosses from Nairobi comes to the county, because, we are better than some facilities. So whenever people from the national government come, they normally bring them to Ewasungiro, at least to see that things work. Even manually, some data is in place, not like in other institutions or health facilities that belongs to government who are situated in the bush. Yeah.
Yeah. And just to also help our students and, just to understand more about the Kenyan health system, could you shed light on how it is structured and how it operates so that maybe somebody is curious to know how things happen on the other side?
Yes, actually, since 2010, when the constitution was actually changed in Kenya, now we have two levels of government. We have the national government and actually the county governments. And the national government is responsible for policy formulation and trainings. And of course, the county government is responsible for, medical care. But, there are very, very scarce resources. There's a lot of challenges, especially for human resources for health. And even the supply chain is a big challenge.
Yeah, so it's more like we have so many challenges on the supply side. The people who are to provide some of these services. And at some point you mentioned that we needed some of these critical human resource. So if you look at how things have been done, how should this critical staff be integrated into the formal healthcare system? So we talk about community health promoters. We talk about some of these nurses at your clinics. So how can we integrate these important cadres into the formal health system, just to maximize the impact and the sustainability that currently we don't have?
Yeah, it is very difficult and very challenging as long as the resources are not available. Because as we speak, even in the government system, they still have a lot of challenges in human resource for health, especially in the rural areas. Many people they even, move into the Western countries where pay is better. Many of them come to the US, they go to the UK, they go to Europe, and they go to Australia. And so they leave the health system really not cared for. So it's a very, very big challenge. And there are strikes every other day. People striking because salaries are delays. When you don't have money for your family, definitely you cannot go to work. And there's a very, very low morals for medical staffs.
Yeah, and I'm also curious, if we were to give advice to some of these external donors, policymakers, investing in rural health. So what would you say are your key priority areas, to ensure that programs meet community needs, given that, we have some of these challenges and gaps in resources?
Yeah, actually, some of our partners, I normally tell them, they just need to fund implementers directly, rather than passing through It's all a lot of bureaucracy, where there is a government to government, partnerships. Sometimes, it will take a year or two for the benefit to reach to the health facilities. But if somebody can be able to finance the implementers directly, that is actually the best way to make things work in Kenya. Mm-hmm. Yeah.
Yeah, financing implementers directly. I know recently we had the financial, gaps that has affected, health service delivery in Kenya. Maybe we might just be interested to understand more about, some of the difficulties that you experienced as a healthcare provider amid some of these, financial gaps and challenges that resulted early in the year.
Yeah, actually, in February this year, there was a stop work order. It was actually it was a surprise for our lives, a very big experience, because there was a stop work order. And, there's a lot of money flowing to our facilities to take care of HIV/AIDS patients. And then after the order, there was a lot of interruptions of services, because quite a number of staffs, we lose quite a number of staffs. And we had to go to the drawing boards and try to plan things afresh. And as we sit here, they see those challenges, and we continue to pray. We are lucky as CHP because, we charge a fee. We do not close shop, and we try to use the resources that we have to provide the much needed services. So, and also some of our partners who normally do not support us directly has to come in, like CMF, who have been our partners for a long time, and some individual people has to come in to try to bridge the gap.
Yeah, and you mentioned HIV services being disrupted. I don't know if there could have been other services or programs that as well were disrupted by these funding gaps.
Oh yeah, quite a number of them. Like the family planning. You see, we had a lot of community services that have been disrupted, that were being funded through the USAID. But, we had two funding grants one from the USAID and one from the CDC. And actually the CDC did not do they did a 50% funding cut. And, but much of the intervention with HIV patients are actually, they went. But we are still getting ARVs, and we are able to use our own resources to be able to manage about 3,000 patients that we have. But some services, like what we call the treatment adherence services, where we go to we do what we call drug refills in the field. Because many patients, AIDS patients, cannot be able to come to the facilities because they live very far away from the facilities. Like in some situation where Orkoroi is, most of the patients that we take care come from the other side of the border in Tanzania. So now we are not able to go. We used to go to them, but now they have to come. Otherwise, if they don't come, they will miss the doses.
So the major challenge was health service disruption.
Yes.
Could there be others that probably you might think about that probably also were impacted by some of these, stop orders?
Even the government itself. Because the government, we had about 3 US funding agencies that are supporting the government, like the Walter Reed, the Family Health International, the USAID, the PEPFAR funding was actually flowing through to these 3 US funding agencies. So they're all affected by the stop work order.
So as CHP, how did you adapt to some of these unforeseen challenges?
Yeah, actually, you see, when something is not there, it's not there. So when you don't have, some milk for the tea, you have to drink the black tea.
Yeah. Yeah.
So we just have to understand and say life must move on despite the challenges. But still we are working with a lot of challenges, even as we speak now.
Yeah, so more like from a health system perspective, how did you adapt or reorganize or re-strategize, as community health partners?
We actually had to adjust our strategic plan, and actually we had to go back to rebudget, and maybe so many staff lose their jobs, and so many services has to be stopped or scaled down. So that's actually the way we are able to, to respond to that. Yeah.
So, looking forward, is there hope, for health access in Kenya, and particularly for the nomadic communities beyond, these funding gaps? Do you see light at the end of the tunnel?
Actually, about last month, I talked to the US Senate technical team in the Mara. They just wanted to understand what actually the impact of the stop work order. We told them the way we feel, and their work was just to listen. And probably we don't know what will happen later on, but as we speak, we are just continuing, with a lot of hope. We have taken it positively and say things have to move forward, because we cannot just, to take care of HIV/AIDS patient is very expensive, or a TB patient. So, but we are struggling as we speak.
So if there was to be funding for some initiatives, will there be a way you prioritize some of these initiatives or programs based on what you have experienced since this happened?
Yeah, especially the, like sample, you see, one of the way we serve the HIV/AIDS patients is actually taking samples. It's very difficult to monitor the progress of a HIV patient if you don't do the CD4 or you don't do the viral loads. So these are very, very important. So that is actually something important, that we really make sure that to be able to monitor whether the AIDS patient is making any progress, you have to do the viral loads and make sure that the gains that we made, we cannot lose them. The death rate, the mortality has really gone down, but we hope we'll continue to maintain that.
Thank you. So, as we come towards the end, I'm just thinking, if there is one message you could leave for policymakers, or maybe for students or practitioners, who are passionate about, improving health access, particularly for the hard-to-reach communities, what would be that message?
Actually, like what I told the team of the US Senate last month, is it's not bad sometimes when it's very difficult to to support somebody for life, but if you need to take our resources, it's always good to pre-own until maybe in another 1 or 2 years you try to get some alternatives, because probably the help is going to go away. So, and I just want to encourage them to continue creating hope. I like creating hope. I really like creating hope, and I normally, like going to the communities. We have to explain to them what has happened, and many of them are a bit more scared that maybe the supply chain will be cut, because even the Kenya government was not ready for it. Yeah, it was not ready for it. So
one message for the student is that, you find opportunities to inspire and to create hope. And I think, that is very, very important. So ladies and gentlemen, that's the end. I can now sit comfortably. And I mean, for the next 10 to 15 minutes, I want you to think about, what we have talked about here, trying to look at access from, different dimensions. And if you have any questions, then I think we'll take the first three, and then we can proceed from there. So any questions from students or anyone in the room?
So things in Kenya have changed for the Maasai community pretty dramatically since the year 2000 to 2025. Some of the land has been divided and people are not living in the large enkongs anymore. More girls are going to school and fathers are being able to see the benefit of sending their daughters to school because the daughters, even when they get married, they don't forget their parents. So could you speak to some of the changes that you've seen among traditional Maasai rural communities over the last 25 years?
Oh yes, like what Dr. Camila said, a lot has changed, but still we are trying to make sure that many changes do happen, because school going children, like in our Tale hospital, actually the surgeon there is a Maasai lady. She's a surgeon and she does quite a number of surgeries, and is a very, very good, role model for the community. And most of the nurses now in some of our health facilities are locals. And actually a lot has changed. But culturally, we still have early marriages. People marry at the age of, we have, 10-year-old being married by maybe 60 years old people. So I know some of these people cannot be able to believe that. And then of course the female genital mutilation, it is still there. There's a lot of resources being pumped into by so many people, but it has gone down a bit. Mm-hmm. But I'm proud of, girls going to school. And they are really going to school. Yeah. So it's a very positive impact that the community is really taking their girls to schools now. Yeah.
Yeah. I think there's a question. Maybe we can take two questions and then John answers, and then we can move forward in that order. Yeah.
So you mentioned government cuts here in the U.S. as having a big impact on managing a lot of initiatives and protocols in terms of managing infectious diseases in the population. And you mentioned in particular like HIV and tuberculosis as being, among the diseases that are really difficult to manage. In addition to tracking, CD4 cell levels and monitoring long-term outcomes with HIV patients, have you seen cuts to critical medications like antiviral medications and, treatments for these illnesses? And also, with regards to like tuberculosis, have you seen an increase since those cuts have happened in terms of prevalence in the population?
Yeah, so let's hold to that and then take another question, somebody else, so that John can respond to. Yes, there's one question this side.
Hi, John.
Hi.
So I was hoping you could maybe touch a little bit more on how conservation efforts are impacting the work you guys do, because I know that the Maasai are a nomadic pastoral community for the most part, and so obviously that means that having greener pastures to like actually access is an important part of how the Maasai tend to move around the county as a whole. So I was wondering if you could sort of talk about the impact of conservation and understanding how they might move a little bit.
Yeah. So John, are you good for the two questions?
Yeah, actually, I've not understood so well.
So apparently she was asking about the impacts of these funding cuts in terms of looking at the HIV viral progression and also the immune response. and whether also, these cuts have impacted on the provision of antiretroviral therapies, particularly for Narok County, and also I think for TB treatment within that particular context, how that has happened and played out. So maybe if you could explain that, and then Jimmy has talked about conservation efforts.
Yeah, actually, I know Grace can be able to explain about what we call the LDL, the LDL, in order to be able to answer a question.
Yeah.
Hello, everyone.
Hi.
So, we have patients who are on our programs, HIV. We have mothers, pregnant mothers, and breastfeeding mothers. So what we did, we increased the amounts of treatment. If they used to take drugs for 1 month, we give them for 3 months. And at 6 months, they can come for their viral load. And what it means to be LDL is low detectable levels. So the virus will not be detected. It's like saying U is equal to U. And we have them detained. Their viral loads have gone down. They have just not been affected because we give them drugs for a longer period. Yeah. And those who cannot come to the clinic, we make arrangements on how to get their drugs with them. I live in town, and I call all those patients living in town in one area, and I drop the medicine for them there. So we are really trying to help them. And we keep on calling them to see that they are taking their medications. Yeah.
Yeah, actually, the LDL is, you only qualify, Asante Grace, thank you so much. You only qualify for extension of supply of under the ARVs if you adhere to taking the medicine. That means if you don't violate the rules, we can even give you drugs for 6 months, so that we can be able to reduce your visits to the facility, because it is very expensive for them to be coming. And we also do not have funds to be able to take drugs to you in the villages. So those are some of the changes that we are making. And then we are also doing what we call the peaky riding, collecting samples, such that we are trying to tap into the government system to make sure that one person can be able to collect samples for about 10 health facilities and take them to the Walter Reed labs, which are in Kericho and Kisumu, and Kenya Medical Research Institute in Nairobi. So, and normally these results take months to, it takes months for us to get the results. So that means if we need to change the treatment regimens, we cannot do it until we get the viral load results. So it's still a challenge. But we are trying to design ways to make sure that we spend less money. So, in order to respond to the funding cuts. And then, of course, we are doing what we call integration of services. That means if you used to see HIV patients as a nurse or a clinical officer, now you can see all patients. You see TB patients, you see HIV/AIDS patients, and then you see the other regular patients. Because most of the staffs have been services terminated because of lack of funding.
Yeah, thank you so much. And then also to Jimmy's question on conservation.
And actually to do with conservation, it's very interesting because, like we work within, I know he has been there, I remember when I was taking them to, we again work at some of the Mara clinics. We passed through the national park. And we are supposed to pay. And I tell them, you are not tourists, but we are passing here through the national park. So when you see an elephant, assume that you have not seen an elephant. When you see a lion, you assume. You tell the game rangers that have not seen a lion. So actually what we are doing, we are integrating healthcare, maternal healthcare, other health services into conservation and environment. So that's actually what we are doing currently. But we need to take care of the wild animals as well as take care of the humans. So we are integrating services. Yeah.
Thank you so much. I think there was another question from John. Or anyone with another question, probably. Yes, John. Because we can take 2 questions.
I was going to ask a question that was similar to Jimmy's, but it's sort of more specifically focused on solutions. So in terms, you talked nicely about the interconnection between people and nature and how that influences people's health. Do you see nature in itself as part of the solution, especially on maybe the preventative side of sort of healthcare? And are there ways in which you maybe can think about partnerships that help with, for lack of a better term, nature-based solutions in health?
Yeah, like what I said is, forest. I've seen a lot of forest here. And we believe in our country, in our community, forest is a moving pharmacy. There are so many remedies that you can be able to extract from these trees. And they will stop your diarrhea, or they can stop your headache. You just need to research on them. And then you can be able to get a lot of benefits. And that's the reason why we make sure that you conserve the environment. You see, there are some places that you don't need to clean the water because the water have not been contaminated, I mean. So if you take care of the environment very well, there will be less disease. So that's why we are encouraging our communities to make sure that they do proper conservation. Yeah.
Thank you. Yeah.
What are some of the most prevalent social determinants of health that you consider for your patient population in the communities that you serve?
Yeah, okay, Chris, you can be able to answer the social determinants. I can give you that opportunity.
So you said what are the social?
Determinants for health.
Social determinants of health.
Okay.
Yeah.
We have churches. Yeah. We also have, in churches, we have pastors. And most of the pastors work in our facilities. So they do both the treatment and they also preach the gospel. Have I answered?
I think it's a bit different.
Yeah, the question was on social determinants, like things that relate to how people live in that location. In Maasai, maybe are they educated? Do they have a job? Do they travel? Or what's their means of transportation?
Yeah. Okay, for us, mostly we walk. You find that a mother can walk carrying firewood for about 5 kilometers. We also have borders on these rough roads, and they cannot reach this mother to maternity. Yeah. So you find that the mothers will deliver before they reach the clinic. So you see the negative part of it. Infrastructure is very poor. I don't even know whether we have roads or examples of roads. So they really determine health. But we have community health promoters who call us and tell us there's a mother who is here. What can we do about her? And we normally arrange for this mother to be taken from the village to the clinic. Some of them have vehicles, but they cannot move on the rough roads, especially during rainy seasons. It becomes very difficult. And we have mothers who will bleed to death because of the poor infrastructure. So we normally ask our patients or our mothers, don't stay at home. Whenever you feel that you are in labor, mostly the men are the pass bearers. And we ask the men, as John said, they are the determinant of whether this mother is going to deliver in hospital or not. We normally also have trainings for the traditional birth attendants. They also determine a lot. You know, when a mother delivers at home, they are given something. So we ask them, if you bring this mother to maternity, we are going to give you an appreciation. And now they get these mothers brought to our facility for skilled delivery. Yes.
Thank you so much. Yeah, John, did you want to add more light on the same?
Yeah, actually, there are a lot of things that influence about which determine. Like even there's a lot of poverty in some of these communities. People do not have income. Like what I've said before, men control everything. So they really determine. And also lack of, their scarce health facilities. We live far from one another. Jimmy knows about how far they are. Some of the first group that came who did some geocoding and mapping, they were actually surprised to see that people travel for about 100 kilometers to come to a health facility, which is actually, and they still need to go back. And they have to pay for either the border or the normal transport system. So there are a lot of many things that really determines the outcomes of health in our communities.
Thank you so much. One last question from a student. Let's see whether a student has a question. If we don't have a student, anyone to ask the question? Yes, I agree. Yes.
John, thanks for the talk. It was really inspiring. So I'm a data scientist. I care about I'm interested in how data can be helpful. So one big question is if we have, for example, developed an app or something like that, so how many people can use that? For example, can nurses who are the primary carriers for a lot of these services, can they do they have phones to use these apps, and do the patients have access to that? What is the kind of population ratio for people owning a phone for this kind of apps? That's the first question. So how many, if we have an app for that, how many people can use that? Another question is, so how can the data how do you imagine that the data can be useful for you guys to get insights of the public health outcomes? And so have you thought of any ways that you think data can be really useful for you to make decisions?
Yeah, actually, the app issue, I don't know many people whether they know what we call M-Pesa.
Mobile banking.
It's actually like a transfer of money. You can be able to transfer money from here in Virginia to Nairobi. It's very popular in Kenya. And everybody now has an M-Pesa. They have what we call the Mulika Muizi. It's very small phones that they can be able to transfer money. And the same phones, you can be able to transfer information through SMS, mass. So they can be able to use apps. The other question is about data. Data is very, very important. Both it helps us plan, it helps us to make decisions, and it also makes us to budget. So when we have proper data, we can be able to really do a lot of good things. Yeah.
I guess we can talk more about that.
You're welcome. Yeah.
Okay, that's it, folks. Let us give a round of applause to John. And also to Jen as well. So thank you so much, everyone, for coming today. We encourage you to still interact with John. We have him for the next 2 days. And also we want to really extend our sincere appreciation to ARII, because without ARII, we couldn't be here. So thank you so much, ARII, for sponsoring this event and for supporting this important conversation. Enjoy your dinner and see you next time. Shirley.